Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. We're continuing our discussion here with Dr. Yuman Fong, who is the San Giacomo Chair in Surgical Oncology and the Chairman of the Department of Surgery at the City of Hope Comprehensive Cancer Center. What's your work with Caltech at this point?
At Caltech, I actually have an appointment in the Department of Medical Engineering. And there, I actually work with Y.C. Tai, who's the chairman of the department, and we work on devices. We work on devices for navigation and tracking. I work with him on new devices for growing cells, and that's because one of the greatest challenges coming up in this next generation of gene medicine is how to go deliver gene medicines at a reasonable price. Mm-hmm. So if you think about all those gene medicine things that are now been designed and are rolling out, they are dosed at hundreds of thousands of dollars or $1 million or more, okay? And the reason for that is because how much it costs to grow gene medicines, meaning viruses, vectors, and cells. So we are now rethinking the entire process of growing cells in order for us to be able to bring the price down so that the whole world can afford it. Because any medicine at $1 million a dose is not affordable by the world. Mm-hmm. And so we are doing a lot of work on that, and we're hoping that will also spill over to how we produce vaccines. And so kind of exciting to be able to work with the best people on a global problem, not just a very, very tiny specific problem. And so, again, that's been another fortunate thing in my life.
And you have also been part of the evolution of the field of surgery and surgical oncology that has now led to a predominance of minimally invasive surgeries, laparoscopic and robotic surgery. Are you part of the testing and development of new robotics equipment as part of the work you're doing?
Seeing how the evolution of surgery has gone from the 1970s until now has been amazing, okay? There was a time when cancer was pretty much a death sentence. Then folks figured out how to go do the right operation for the right patients to be able to produce a potential cure, even in situations where it seems really dire. So let me take you back to the most common disease I treat. The most common disease I treat is metastatic colon cancer that's come from the colon or the rectum into the liver. Mm-hmm. Therefore, by definition, it had to have been in the bloodstream and traveled up there. And so when I graduated from medical school in 1984, that was stage 4 disease and incurable. Our chemotherapies were terrible, and we would just say, I'm so sorry to the patients and let them go home and die. And generally, they died within 6 months. Then we figured out that in many of the patients, it's only in the liver. And the reason for that now is obvious, but back then was not so obvious. The blood that drains from the colon actually comes through a blood vessel called the portal vein, and the portal vein goes to the liver first. And the liver is such a good filter that many times it doesn't go anywhere else. And the liver has so many immune cells that it kills off most of the cancer cells. So it takes millions of tumor cells to reach the liver for a few spots to form. So starting in the 1980s, that became very, very clear because CAT scans were born. We were able to watch what happens inside as the disease develops. And then surgeons started removing the tumors from the liver. And what we have learned in the last 40 years is that if you can remove all the spots, a third of the patients are cured. They die of old age. They die of something else entirely. And now with good chemotherapy, the likelihood that someone who has metastatic stage 4 colon cancer in the liver is alive 5 years later is over 50% if they are treated. So then the next transition, once we realize how many more patients we can cure, not just in this disease, but in many, is to try to go less invasive, okay? That's because in the 1980s and 90s was about how many giant operations you can do, okay? And that was surgical virility. And And I have nothing against that, okay? It's just that we're in a kind of gentler time now, okay?
Maybe you're more secure.
Yeah, we're in a kind of gentler time now. So I still remember when laparoscopy first came in, and it was just used to take out gallbladders or gallstones, right? Then people said, well, why don't we do bigger operations this way? There was a huge resistance to doing liver surgery laparoscopically. And,
why was that?
That's because, again, it just seemed foreign. And early on, people started finding recurrences in the port sites and other things because we weren't doing it with the right technique. Mm-hmm. And so there were many bad things that happened early on that spooked people. But as I reflect back, it's because how hard it is to retrain. If you are the best liver surgeon in the world with open surgery, now somebody says to you, you have all these new instruments that you've never used before, and now you have to go back to step one. Are you still willing to do that? Okay, that inertia is really hard, and I get that. And that's why every time now we invent a new instrument, we now go and say, how do we retrain people as quickly as possible to be experts? So laparoscopy came in, then robotics came in, and now it's very clear that many of these operations that we used to make giant incisions on, we could put in 8mm incisions and get the tumor out. So many of my patients now, if I can do surgery robotically, they go home the same day or the next day rather than be in the ICU for 2-3 days like it used to be and be in the hospital for 7 to 10 days like it used to be. But even more than that, within a week to 10 days, they're back to normal. It's not the 6 weeks to 3 months that it used to take. So that's why now I go, more cures, less invasive. More cures, less invasive. They go hand in hand. And how do we go and deliver that?
And I know a few impressive things from seeing some of your presentations, and that is, it's not just for 1 or 2 kind of oligometastatic spots. I've seen some of your pre-surgery, pre-neoadjuvant therapy scans of livers that are riddled with disease, and it's astonishing to me that those are still candidates for surgery, and you have long-term outcomes that show many patients are doing amazingly well with scans that you would be horrified looking at initially. Yep. So I guess my question is, one of your key points is that this is very underutilized. And what do you see as the leading friction points, the resistance? Is it that people still do not believe that metastatic disease is more nuanced than a binary, you have it or you don't? Or is it access to qualified surgeons? What?
I think it's a number of things, but a lot of it's really education. Hate to say it, but after fellowship is usually most people stop learning, okay? And that's because they get into a busy clinical practice, and then it's really hard to learn new things as we go. So back in the 1990s, I still remember when we first started removing liver tumors routinely, we would say, only singles, okay? Only somebody with a single tumor and nothing else. Then we said, less than 5. Then we said less than 10, okay? Then we said response to chemotherapy if it's more than 50, okay? And now it really is tailored. But learning how to go approach somebody who has 10 tumors is different than somebody who has 1 tumor. And so how do you go tailor the therapies? But I think a lot of it, the reason that's underutilized, and it definitely is underutilized, is partly because most people still don't know that stage 4 metastatic colorectal cancer is potentially curable. So in California State, we looked it up, and we believe that probably about 1/3 of the patients with metastatic colorectal cancer actually should have an operation to go deal with their tumor locally. In California, only about 4.5% of people are in the last decade, okay? And that's a huge discrepancy. And that's because if somebody only gets chemotherapy, highly unlikely they're a 3-year survivor. And almost certainly they're not going to be a 5-year survivor. And just by operating, even if you don't cure the patient, half the patients will be 5-year survivors, okay? And huge difference in outcome, and also a huge difference in cost, because our chemotherapies are now not cheap.
Yeah, that to me was interesting. Like all of that, and it actually saves money is amazing.
Yes, because if somebody's actually cured after an operation and only gets adjuvant chemotherapy, they stop, okay? And then they go on with a normal life without any additional suffering from the disease or cost of the therapy. Whereas if somebody is alive for 2-3 years on chemotherapy, we're constantly not only causing suffering, but having cost of the chemotherapy. And sometimes for chemotherapies now for metastatic colorectal cancer, it's as much as $150,000, $200,000 every 6 months, okay? So it's a huge amount of money too. So that's why I think it's education, because I don't think it's just that somebody looked at the balance sheet and said what it should be, because if they did that, they would send the patients also.
But are there enough qualified surgeons with that expertise to handle the volume that you'd hope to see if enough people were being referred appropriately? Is this something that has enough qualified people to do it, or do people need to go to just a few centers with the most expertise and volume?
Yeah. So the answer there is yes and no, okay? And so let me come back to why yes, why no, and which question, okay? There's no doubt that surgery, high-end surgery like liver or pancreatic surgery, is done better and safer at a high-volume center, okay? So in most countries in Europe and in Asia, there's actually legislation that says you cannot have liver surgery except at a high-volume center. So in the Netherlands, for example, they say the number is 20. If you don't do 20 in your center for a year, you can't actually do the surgery. And when they legislated that 10 years ago, now, when they look back, they cut the mortality in half in the nation from this kind of surgery. So it's wonderful, okay? Are there enough surgeons trained to go do high-end liver and pancreatic surgery? The answer is yes, okay? And there are some very qualified centers and people around the country. And therefore, having enough surgeons to go do the work is not hard. Getting the patients to the right centers is hard. Okay, and that's because there are many, many both financial and cultural and just logistic obstacles to doing all of that. The financial is we're not a single payer. If we were a single payer, that single payer would just go and say, boom, let's just put it at the highest center that has the best outcome, right? And even within states that have limited payers, it's not so universal that you can actually go do that. And within each payer system, there's not always enough surgeons to go do it. So that's why nationally I think we have enough liver and pancreatic surgeons. Within each payer, we may not. Okay, that's the problem.
With all of the developments, first in minimally invasive surgery and the skill set required for that, and then increasingly with robotics, and I know you're still involved with further advances in that, is that distributed in a way that is feasible, or are we getting to a point where there's a few centers that are the extreme halves and then this gulf between them and the centers that don't? And is it necessary? Are these things that truly impact outcomes clinically, or are these just nice to have conveniences?
So let me reduce that down to just robotics, okay? And that's because there are many devices where you could argue, should everyone have it? Should some people have it? Yeah. And if you have it, what should it be used for? And that ranges from everything from robotics to proton beam therapy, right? Yeah. Okay. And so let's just talk about robotics. There's no doubt that there are certain operations that done robotically is more feasible and better than open surgery for sure, and is easier and better than laparoscopy in many times. Not all centers have them. I have robotics. Okay, and so if someone actually has a tumor that's perfect for removal by robotics that gives them the best chance of survival while optimizing their recovery, should we legislate it go to someplace with robotics? Hard to do because it's really highly case individual, right? And individualized. Now, that being said, not all the places with high-end robotics is all academic centers. Some very, very high-end community hospitals or network hospitals have decided to invest in robotics because they have local surgeon expertise. They drive a portfolio of excellent robotic medicine. And so then you can't even just say it's tertiary referral centers, right? It's really high volume centers for whatever it is that you're looking for. That's why how we go and legislate that high-end surgery should be done at high volume centers and not just in tertiary care centers. How we encourage insurance carriers to actually contract at least with some high volume center for each disease that they're covering. Okay, so that their patients actually get the best outcome. So I actually proposed an editorial recently that insurance carriers should be graded according to whether they actually have contracted for high volume care for their patients for high-end work.
How much of an impact have improvements in systemic therapy made in the feasibility of surgery or other local interventions for cure? I mean, how much does improved systemic therapy raise the bar?
Yeah. I'll answer that question in two ways, okay? And I'm going to take it from one side where have systemic therapies gotten so good that we don't need surgeons anymore? I've been hearing that for 35 years, okay? Ever since the first day of my career, that people would go, oh, no, in 5 years, we won't need you anymore.
So I'm going to guess your answer on this.
Yeah. Think about solid tumors, any solid tumor, except for germ cell tumor. There is no solid tumor that's cured without surgery, okay, except germ cell tumor. And so I think that answers a huge part of that. Surgery is at present still a very, very important part of the multimodality treatments. But highly effective systemic therapy clearly has made our jobs better, okay? Better in the sense that we now provide for many more patients to have definitive therapy. We can now see those patients onto lives that they used to have and see them go back to their families and see their families grow up. And so that's all good. So by giving effective systemic chemotherapy, we now have a pool of patients that were kind of borderline for resection where there's enough reduction of tumor that allows us to resect. There's even a group of patients that were truly at non-resectable stage 4 where we're reducing it down to resectable. Every time I see somebody with over 100 tumors in the liver from metastatic colorectal cancer, unless chemotherapy really, really worked and wiped out 75 of those tumors, highly unlikely that anything I do is going to make any difference. But every now and then I see that. 10 to 15% of the people, non-resectable, will be reduced by successful systemic therapy to something I can then manage. And so, again, it's all going hand in hand. But the flip side of it is that many of these systemic therapies cause terrible side effects, okay? So I still remember the first perforation from Avastin I saw, okay? It was one of my patients who was on Folfox and Avastin for metastatic colorectal cancer. The primary cancer was still in place in the right colon. And he came in one day with an acute abdomen. And it was basically the tumor melted away in the right colon and it perforated, okay? And so now we're even asked to operate on folks that actually have complications from the different therapies. And then when we do operate, many of these agents actually have side effects that are surgically relevant, okay? Wound healing, immune cell function for infections after surgery, recovery of certain clotting factors that are necessary for patients to be well long-term platelet function or dysfunction in terms of thrombocytopenia. These are all now new things that we have to think about every time we see somebody on multiple agents for a terrible cancer.
You've written and spoken about some of the non-surgical local therapies, ablation procedures and embolization. How do those integrate with your overall management options in terms of where do you select surgery versus a non-surgical approach?
Yeah. So development in MIS therapy, minimal invasive, the S is surgical, but it's really minimal invasive therapy is what it is not just surgeons, okay? It's interventional radiology with needles and catheters. It is our laparoscopic surgeons with PIPEC, which is aerosolized chemotherapy, which I think of as chemoablation of tumors. It's all a matter of what is the right tool that is the least invasive for giving the patient the best therapy. So now with microwave ablation, that's taking a needle that it really is a microwave antenna. We put into tumors of all types. It could be in the liver, it could be in the lung, it could be in the bone, and we could actually then burn a tumor to death, heat it up to 100 degrees. And no cell survives 100 degrees Celsius, okay? And so it is an amazingly effective therapy for a limited number of tumors. So when I first started saying, and it's not just me, it's all of us that believe in such therapies. So 20 years ago when I said, needle ablation probably will cure small tumors and we probably don't need to operate on those, I was the heretic and we were all the heretics. We would be excommunicated and we'd be in the forest for a while. Okay. But now there's so much good data that says small tumors in the liver, particularly deep ones, instead of cutting out half of someone's liver, put a needle in it and in 20 minutes, cure the patient and send the patient home on the same day, okay? And so a lot of this now that we take for granted, it was actually hard work trying to convince people that that's the right thing to do, okay?
And so this really needs to be individualized by looking at the extent of disease and the geography within the liver.
Right. But that's also where specialized centers come in. If you don't have the tool, you're not going to even think about using it. Okay? So if you don't have nanoknife treatment or microwave ablation or chemoablation of tumor tools that are set up to go and have the expertise to use them, you're not going to even think of that as part of the alternatives to major surgery of some type.
I think one point that you mentioned in passing that is really worth underscoring is that we think and talk about cure as being obviously the ultimate ideal endpoint. But if you fall short of that, there's plenty of potential clinically meaningful benefit, even if a patient does have a relapse later. If you've improved their survival by intervening with local therapies and they get many months or probably more likely a few years of benefit, if we're giving just systemic therapy for metastatic disease, we consider that a huge success. So it doesn't need to be reduced to a binary, did you cure the patient or not?
Yes. Cure is always nice, but there are many tumors we take care of that are slow growing, that you don't actually need to cure someone. You don't even have to kill all the tumor in order for somebody to live a long time. So I lump into that group of tumors things like mucinous tumors that are of the appendix, neuroendocrine tumors either of the pancreas or the small intestine or the lung, even small hepatocellular carcinomas, okay? So let's take neuroendocrine tumor. This is a tumor that starts in the cells that make hormones, and some of them are carcinoids, but it's a much bigger field than that. Many times patients will come to see me with 20 of these in the liver. It's come from either the pancreas or it's come from the small intestine. Trying to decide what to do for those folks used to be a huge debate, okay? Should you take someone who has metastatic disease and multiple in the liver, and you know there are another 50 in the liver, every time you see 20, there are another 50 that are going to grow. Should you treat those people at all, okay? And over all these years, what we have come to realize is that it's such a slow-growing tumor that if you could decide to reduce down to minimal disease, people live a long time and they live very good lives. So I have patients who I will go and try to reduce their liver by surgery to start, and then down the line by embolization, down the line possibly by needle ablation, down the line by possibly radioembolization, and possibly take them back for repeat liver resections and cytoreduction, where they now live decades. And every time I receive an invitation to a wedding of a child where I know that child was like a baby when I first met the patient, it's like a wonderful day, okay? And so there are many diseases like that where first day I meet them, I say, no chance of cure, but a great chance I will know you decades from now. It still makes a difference.
Of course. And I think this is also one of those concepts that has implications across oncology, because I treat a lot of patients with more indolent lung cancers, and I would say that it can be a mistake to paint with too broad a brush and just say, well, you have multifocal metastatic disease, there's no role for local therapy, or of course the radiation oncology community is increasingly doing studies and very engaged in radiation for oligometastatic disease with a variable definition of what makes oligo. But I think exploring the questions of what is the potential benefit of local therapy for a potentially slow process, debulking, especially when we have systemic therapies, whether that's chemo, which has often modest but meaningful benefit. Targeted therapies can have major benefit, and immunotherapy is a bit of a wild card that may be stimulated by radiation. So if we were to think of an approach of surgery or radiation combined with increasingly effective systemic therapies, we can potentially do things that we didn't think were possible a decade ago. One other thing that I think is quite interesting is some of the endpoints that you use, and I don't know how much you use them for publication versus just tracking them. Things like the movement, the ambulation of your patients post-surgery. Mm-hmm. Can you talk about that and how well that serves as a surrogate for other clinical endpoints?
Yes. The world of telemedicine is here and coming, okay? And it's no longer in the future. It's really right now. And Telemedicine really comes in three ways, right? One, most people just think of it as a consultation that you do from far away. Okay, yes, that's part of it, and so that people don't need to drive. But that we've had for a long, long time. If you think about the state of Missouri, they actually put in an entire network in the state of Missouri so that patients who live in rural Missouri don't need to drive all the way to the big city for a cancer consultation. And every small community hospital actually is funded by the state to have telemedicine, okay? That's been going on for a long time. The way I think of telemedicine as the most exciting coming up, though, is how we monitor patients and then how we treat patients at home. It's both. So the monitoring we are starting to do, and many companies are springing up. So if you think about my liver surgeries that now I'm sending home that same day or the next day, we have an obligation now, because these patients that used to stay in the hospital for a week to 10 days, of making sure that those patients are safe at home. So how do you do that? And do you do that with a regular phone call by a nurse to the families? That's how it used to be done. And but then the patient was doing really well and out shopping or out skiing, you wouldn't catch them, right? And so we've been sending people home with activities monitors, trackers. The brand I use is a Garmin brand. I get no endorsement fees for Garmin. I use them because they have a device called a VivoFit that is waterproof, so my patients can shower. All health devices have to be usable by the patient, okay? It has a battery that goes a year, so there's no recharging. All health devices have to be usable by the patient without difficulty, okay? And so now I track the patients and I know every day how many steps they're taking. And if it drops off, it usually means something bad is happening, and then we go track them down and making sure that they come in to see us. But there are now services that will go do that. The next step we are taking, and this is quite exciting, Jack, is that we're about to go try to do rehab at home by monitors. And we're starting with breast rehab. That's because when somebody has breast surgery, rehab has been shown to prevent lymphedema, increase ability to get back to normal functions, and they could be normal things like combing your hair with that arm, cooking a meal for yourself, being able to shop for yourself, and simple things require a functional arm. But 80% of American women who have surgery don't get rehab. The reason they don't get rehab is because either they live too far, their insurance doesn't cover it, there aren't enough occupational therapists. So we've developed a sensor system that allows patients to go home and do exercises. We tie it to an app that actually has them set their goals. Is it combing your hair, okay? Is it cooking? What is it? And then has the stress scale on it that allows them to report to us their level of anxiety, level of pain, level of stiffness, all those parameters that doctors oftentimes forget to ask, but are really important for gauging the trajectory of recovery of a patient. We're now testing that about to test that in volunteers in the hospital, and then to test it in patients getting rehabbed in the hospital to make sure that the fidelity is good. Then we're going to go roll it out and see whether we can actually reach rural areas where patients will go home after breast surgery and see whether we can guide their breast rehab at home this way, and whether the data will then fall back into a pathway analyzed by the computer, that if they fall off path, we contact them and get them in. If they are on path, how do we give them an electronic cheer and keep them going? And we believe this will also motivate people to actually do their exercises at home, because that will be a way of seeing and gauging how well they're doing.
I think one of the other factors that is really important is that patients don't have to hook up stuff to send the information back. It's all readable without, the user interface is totally intuitive or negligible, that you can just have the data fed to you rather than having them have to connect it. I think that's certainly a challenge. I've also seen some interesting exploratory work being done looking, and this is by some investigators in Southern California, looking at a kind of Google Maps-like application, looking at the distance that patients are traveling in their daily lives as an indicator of their overall vitality and clinical outcomes if they are on systemic therapy for cancer, for instance, and being a warning sign if their distance traveled, if their radius of movement is going down over time. So interesting stuff, and I think a lot more to do there. I know, because I'm increasingly involved with City of Hope's efforts to build telemedicine. Have you used yet, or do you see the potential for having pre-op and post-op visits also in a kind of what we think of as telemedicine capacity?
I think that will be so useful, because if we're asking patients to come to tertiary cancer centers or high-volume centers and drive miles in order to get the right therapy, we need to go figure out how we deliver all of the things that go with it closer to home. Okay? Some of that will be done for us by referring physicians and local doctors that will help us deliver the care, but some of it has to be by telemedicine of some type. And I'm also convinced that in the next generation of planned communities, that folks are going to start thinking, how are we going to put sensors in the home? Mm-hmm. Especially if it's going to be a community that's going to be of older people. Will we now have not illness monitors and trackers, but health trackers, okay? And that is built into the entire complex that actually allows us data to help patients be healthier and to get help sooner if they're not healthy.
And I would love to see some of these communities have a telemedicine facility where people can get their EKGs done right on site and have that sent to an ER and be able to interact with physicians through a telemedicine visit without them having to worry about hooking it all up in their own home if there's a room on site that's telemedicine equipped. Mm-hmm. So thank you so much. It's been a great conversation, and I had really no idea of the breadth of activities that you're doing, which, any aspect of that would be impressive, but with, the shooting, the comics, the Olympic training, and on top of leadership and really developing the field of metastasectomies and changing how we think about the role for local therapy in what we've generally just dismissed as metastatic disease. All amazing stuff. Thanks so much.
Yep. Thank you, Jack.
Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.